So a number of people have said, why is a charity like JBD talking about diabetes? And for me, the answer is simple. We see firsthand every day the human impact when diabetes is not identified early enough or not managed well. Unmanaged type 2 diabetes can lead to life-changing complications, including sight loss, mobility problems, and amputations. Many of the people attending our sight loss groups have diabetes-related sight loss. And over the years, we've also seen more people coming to us for housing and support following diabetes-related complications. As a charity, we felt we couldn't ignore it. If there's something we can do, not only to support people once disability occurs, but to also raise awareness and help prevent avoidable harm, then we believe we have a responsibility to do this. The work we're doing is not just about Jewish people already living with diabetes, it's also for people who are pre-diabetic, who have a family history, who may be worried about the risk, or who simply want to understand more. The good news is that by making changes early and by understanding risks, many people may be able to change that course. These events are here to provide information, practical advice, and a space for conversation. The evening isn't around blame or fear, it's actually about kind of hopefully prevention support and community. We want people to feel leaving better informed, more confident about what questions to ask, and reassured that they're not alone. Thank you all very much for coming along. I'm going to hand over to my colleague Aidan, who is going to chair this evening for us.
My name is Aidan McCarthy. I am Director of Housing Management and Community Services at JBD. The people who are speaking with us this evening, we have Dr Bernard Freudenthal, who is an endocrinologist. We have Dr Zanne Lewis, who is a GP, and Ruth Kander, who is a dietitian.
A bit of background about diabetes and try to address some misconceptions as well. So, diabetes is an incredibly broad description of lots of different things. People have different ideas in their mind about what diabetes is. Is it an autoimmune disease which requires lifelong injections of the replacement hormone insulin? Is it just an acquired condition of the Western lifestyle which may affect people in older age? Is it something people should feel blamed for? Definitely not. Is it a disease with genetic factors? Is it just a silent condition diagnosed on blood tests which you may have no symptoms from at all? So the truth is it's all these things and different things for different people. And this is why there's no one-size-fits-all approach, and having some understanding can help with one's individual approach. So in terms of some statistics, the people have heard of the type 2 diabetes epidemic. So apparently almost 6 million people in the UK are living with diabetes, and 1 in 5 adults have either diabetes or pre-diabetes. A large chunk of those are asymptomatic, and these days up to 5% of them, or just under 5% of them, are under the age of 40. So it's not exclusively a disease of old age. Now we've heard of the type 1 diabetes requiring insulin because of the body's not making insulin anymore. But in type 2 diabetes, people tend to have excess insulin because it's actually a disease of insulin resistance. The other aspect of treatment which most doctors would propose today is that the medical treatment should be personalized and that it should prevent the reduction of complications of diabetes. So the big consequence of diabetes is increased cardiovascular disease, and people die of heart attacks and strokes, and also diseases of the blood vessels caused by diabetes then lead to issues affecting the feet and the kidneys and the eyes, so big blood vessels and small blood vessels. And the treatment which one adopts for diabetes should prioritize the cardiovascular benefit. So, and we do live in a revolution right now in type 2 diabetes treatment, where the best recommended treatments and all the guidelines are treatments which prioritize the reduction of complications more than just prioritizing the reduction in blood sugars. So using insulin and also treatments such as glycoside, which some people may have heard of, which simply lower sugars but don't provide direct cardiovascular benefit, those are treatments of a last resort. So we have a very advanced and comprehensive diabetic eye screening program in the country. So even if one gets one's diabetes into remission, one should still attend eye screening appointments, and they then refer on to ophthalmology clinics if preventative treatments are required. I talked about prioritizing risk reduction rather than blood sugar control on its own, and it's important to have a personalized target. One wouldn't want to achieve perfect blood sugars just with medications or interventions such as insulin, which solely reduce blood sugar levels, but don't actually reduce the risk of complications. And the risk of complications, of course, relates to the length of time which one has diabetes and how many decades one has ahead, and what the kind of stringency of intervention which might be required at a younger age may not be the same at an older age. So if one has mild type 2 diabetes diagnosed at an older age, it may not in its own actually be such a major cause for concern, as much as if it were diagnosed at a younger age. The Diabetes Pathway to Remission program, where anyone can be referred by their GP to a health promotion program, which has different providers in every local area of the country, which supports people with dietary interventions rather than giving medications in order to actually achieve remission. So this isn't some wacky thing people have to do by reading weird books or getting alternative information from the internet. This is now actually being directly promoted by the NHS, which is quite a turnaround in the professional approach to this. There's also the NHS Diabetes Prevention Programme. So if one has a diagnosis of pre-diabetes, there's a specific health program which one can be enrolled in, which helps reduce the incidence of subsequent type 2 diabetes. The reason for getting the right diagnosis is because if you know the cause of your diabetes, then you can get the appropriate bespoke treatment. I was talking about having a sort of treatment which is responsive to one's situation. So if one starts off with insulin and actually shouldn't be on it, then you can't just wait for a whole year to then come around to your next review to rethink things. Nor should one's reviews just with a doctor or nurse be just a spectator sport of documenting where things aren't quite right and say, try this and see what happens. Sometimes you do need to try and turn things around in a slightly more timely manner, and then I think one should ask one's doctor how soon can we sort of review things again. And often the blood test which is used to see blood sugar control and choose treatments is called HbA1c, glycated hemoglobin, which shows how much blood sugar, what your average blood sugar has been over the past 3 months. It looks at the amount of glucose or sugar stuck to the outside of the red cells in your blood. It's a fantastic test, but you can do that every 3 months. So it doesn't make sense to wait a whole year. If you've started a new drug and you want to know if it's made a difference, you need to sometimes be on it yourself to make sure that the test is done in another 3 months' time. So I'm going to stop talking then now. I hope that wasn't too much information. And I'll pass over to Zanne.
Okay. I'll just follow on with that, giving a GP perspective on type 2 diabetes. So we've all heard how important it is to attend your checkups with your GP practice. So every GP practice will have different ways of organising their follow-ups and how they see their diabetic patients. For example, in my practice, we do it by your birthday month, so we will invite you in and come and see our healthcare assistant in your birthday month, who will do your foot checks and your blood pressure and all your blood tests that you need. Also check that you've had your annual eye checks. Some people need them more often, but most people will just have it annually. That does get recorded centrally from the big computer in the sky. Actually comes into all GP surgery computer systems, and will recall people who are diabetic. So please make sure that you do attend, as we've heard how important it is to attend your eye checks and your checkups with your GPs, however they organise that. And as you've heard, it's really important, not just, we're not just interested in what your sugar levels are. Diabetes, at the end of the day, is a metabolic disease. It affects every system of the body, and it's really important to make sure that all of your risk factors are being looked after, so, such as your blood pressure and your cholesterol, that you're not smoking, really, really important. Smoking is a really, really bad thing for a lot of things, but especially if you're diabetic. Really increases your cardiovascular risk. So, you know, we need to take a whole holistic approach to diabetes. It's not just about blood sugars. They're very important, but it's really important that all systems and everything are looked at. There is such a thing as an NHS health check. I don't know if anyone's heard of that. So basically anyone between the ages of 40 and 75 can have a health check. Again, in my practice, it's done with our healthcare assistants. We'll give you a little bit of lifestyle advice as well. And within that check, we will be checking your hemoglobin A1C, which, as you know, is what we measure how well your glucose is controlled. So everyone can have that every 5 years. But if that is picked up through an NHS health check or another check, for example, that you are pre-diabetic, then you should be having annual checks with your GP with regards to what your hemoglobin A1C is. So I just thought I'd talk a bit about what pre-diabetes is. So it's also something that's called non-diabetic hyperglycemia. And it means that your blood sugar levels are raised, but not high enough for a diagnosis of type 2 diabetes. And it usually has no symptoms, and so can only be picked up on a blood test. So in England, about 5.1 million people have pre-diabetes. And across the UK, about 1 in 5 adults are living with diabetes or pre-diabetes. The statistic I could find was that you have about a 16% chance of progressing to type 2 diabetes within 3 years once you've been diagnosed with pre-diabetes. So, as we said, it significantly increases the risk of developing type 2 diabetes, and then following on from that, we've heard the cardiovascular side effects of diabetes. But the good news is that it is preventable. And the mainstay of treatment of prediabetes is lifestyle changes. There's no medication for prediabetes. It's all about lifestyle. Obviously, if you've got hypertension or cardiovascular disease, you're at high risk of developing diabetes or prediabetes. And any kind of sedentary lifestyle, poor diet, you're at high risk of developing prediabetes. Physical activity, part of a lifestyle change, is really important. The current guidelines are that you should be doing about 150 minutes a week of moderate activity. I personally think we probably should be doing more than that. I could go on forever talking about physical activity, but I won't. But it's really important not to be sedentary, to move as much as you can. Get up and walk. If you can, park your car further away from the shops and walk to the shops, go up the stairs, don't use the lift. I know not everyone can do that, and I emphasize for people who can't, but it's really important. People who have been diagnosed with prediabetes are eligible for a NHS diabetes prevention program, which is also known as Healthier You. You can self-refer yourself. If you just Google it, you'll find it. You can only do it once, unfortunately, so if you've done it already, you can't do it again. Or your GP can refer you. And it involves a program, either a group program where you'll meet up with health coaches and things like that to try and basically institute some lifestyle changes, or it can be a digital program where it will be online, and you again can meet up with health coaches online and things like that. The bottom line is that prediabetes is very common. It's silent but can be serious, but it's highly reversible. It's all about lifestyle. Knowing your numbers and taking early action can dramatically reduce your risk of developing type 2 diabetes. And the NHS offers free evidence-based support that will enable you to do small, sustained lifestyle changes that make a really big difference.
Hello, I'm Ruth. I'm going to talk about healthy eating, but I feel like a lot of people think it's very boring, or they feel like food police, can't eat anything, you know, everything that's nice I can't have. So I think it's just trying to show you and educate you in a way that you feel that there are lots of options of foods to eat, and understanding that when it's okay to have a treat, but then making sure that most of the time you're eating in a healthy way. And we know that what we eat impacts our blood sugars. So if you do have diabetes or pre-diabetes, most of what you're eating will affect that. So if you're eating a lot of sugary foods or a lot of heavily processed food, it will make your sugars go up. But we also know that if you're having foods that contain more fiber, which I'll talk about more in a minute, don't make your sugars go up as much. And that's what we're trying to do. We're trying to make sure that your sugars don't go up very high and that they stay quite stable, and we keep them in a more like a steady pattern and not kind of jumping up and down in lots of peaks. So thinking about the different food groups, so you've got carbohydrates, which are starchy foods, so like rice, bread, pasta, and then you've got the fats, and Bernard alluded to the whole, you know, the low-fat diet, but actually healthy fats are really good for us, so things like olive oils, avocados, nuts, oily fish are good fats, and they're really good for us. But then you've got the less good fats for us, so things like pastries and pies and processed meat have got fats that are not so good for us. But fats do not affect blood sugars very much. So if you're having a meal and you've got some fats and some protein, which I'll talk about, it doesn't affect your blood sugars as much as if you had a big plate of pasta, let's say, okay? And then you've got proteins, which again we want you to have with carbohydrates because it limits the amount of rise in blood sugars. So protein foods are things like beans, lentils, tofu, soya, chicken, fish, meat, eggs, and dairy products, and all those are good foods for us. So those are the three kind of groups that we want to think about. And I try to talk to people in terms of meals, because I think that's what we do. We eat, you know, meals in a day. So if you're thinking about breakfast, and I'm quite mindful that not everybody wants to eat breakfast or can eat breakfast or likes breakfast. Lots of people don't like breakfast. But I think that if you're eating 3 times a day in a regular pattern, that's much better for blood sugar management, much better for your weight control as well. Because if you're not eating on a regular basis, you get very, very hungry, and then you just want to grab everything that you see, and they might not necessarily be the healthy choices. So if you're eating in a regular pattern and a little bit more being organized about it, you're going to make much healthier choices naturally, and it's much easier as well to have a healthy diet. And I also have this kind of I don't know, theory, if you like, or recommendation to people who need to manage their blood sugars or trying to manage their weight, to think about their eating schedule as a 12-hour eating schedule. So, you know, you start at, let's say, 8 o'clock or 9 o'clock in the morning till 8 o'clock or 9 o'clock at night, and that gives you a much more controlled eating pattern, and then you have a meal every 4 hours. Doesn't always work like that, but it's a good way to think about placing your meals and having a healthy balance. Half the plate is vegetables, a quarter protein and a quarter carbs. And actually, it's a really good way of knowing that you're eating the right amount of food. And it's not childish and it's not babyish. And actually, this is a china plate. Some of them are really horrible plastic plates that you can find. But this is a normal-sized dinner plate. And it just shows you how to portion your meal. And it's a lot easier than just gauging or trying to work it out. The other things I've used with people are these. I don't know if you've seen these at all on Amazon, but they're like portion pots, okay? So they say in front what you should have in them. So this is protein. It's a bit small, actually, to be honest. This is for vegetables. This is for fruit. And this is for carbs. This is actually a good measure for like grains, so like rice and quinoa, bulgur wheat, or buckwheat, or pasta, and that ensures that you don't eat too much. And it fits very much with this half, quarter of the plate. So thinking about that. Thinking about the carbohydrates to choose. So I'm very much in favor of choosing carbohydrates that have got more fiber. So fiber is really good for your gut health. It's very good for the bacteria in the gut, makes you more regular, okay, so prevents constipation. Quinoa has got triple the amount of fiber to rice, and the rise in blood sugar is much slower. It's actually got more protein in the grain, so it's overall much healthier. And then you've got grains like buckwheat, which again, much higher in fiber than rice and pasta, and also a slower rise in blood sugar, and then bulgur wheat as well. And all these are available in the supermarket. I'd really encourage you to try them out, like one a week or one a month, and cook it instead of having potatoes or instead of having rice and pasta. And you'll see it's a little bit of an acquired taste, and you do need to flavour it with garlic and paprika and pepper and put lots of vegetables with it, but just I promise you it tastes really nice. And then you've got potatoes. So white potatoes, if you know, a large amount of white potatoes will rush into your bloodstream and make your blood sugars go up, but then sweet potato, oddly, doesn't do that as much. So sweet potato is much better than white potato. I actually very much encourage, you know, the mini new potatoes, because I think they're more quantifiable than a big potato. So having, you know, 5 of those with your meal is absolutely plenty, really. And again, they don't rush in and make your blood sugars very high. So thinking about those kind of things, so if you're thinking about, you know, breakfast, lunch and supper, and thinking to incorporate all those things, so in terms of breakfast, something like yogurt and berries is a perfect breakfast, or if you wanted to have something like some eggs and avocado and some chopped up cucumber and tomato with a slice of whole grain bread, amazing breakfast. Or if you just wanted to have a bowl of Weetabix or shredded wheat, that's also fine. And then in terms of lunch, so some people, if you're going to have lunch as your smaller meal, something like a two bread sandwich with tuna or chicken or salmon, and then a salad on the side. So, you know, tomato, cucumber, carrots, sugar snap peas, anything really, radishes, anything, it doesn't really matter, anything you like on the side to give you a bit of extra and to fill you up more. And then in the evening for dinner, having, you know, some quinoa with a salmon fillet and half a plate of vegetables or broccoli or cauliflower, whatever it is you like, is actually a perfect meal. And trying to limit treats and snacks for times when it's a birthday or an occasion, or if you're going out to a meal. I always say to people, if you're going out for a meal and you're going to someone's house for dinner, don't sit there and not eat. Be stricter before you go and after you've been, and go and enjoy. Similarly, if you're going to a restaurant, don't sit there and think, I can't eat anything. Go and enjoy. You need to enjoy life. Yeah, we all need to enjoy life, but be limited, you know, and be healthy most of the time. So that's where the 80-20 rule comes in. So 80% of the time, you're being quite strict about what you're eating. You're eating really healthy, fresh food, as little processed as possible. And then 20% of the time is the time when you go out, or the weekend, or a celebration. And then I wouldn't use it as an excuse to have excess, but have that little treat that you really love. And I think if you do it like that, it works much better, and you don't feel that you're being denied food. You don't feel that you can't have your special treats.
Wonderful, great. Thank you to all 3 speakers there for some really interesting, informative, and I must say really, really positive talks there. It was fascinating to hear the history of diabetes. I won't be repeating the name of Thomas Willis's treatise from the 17th century. It was also very interesting to hear about just the very positive message about how, not easy, but that pre-diabetes can be addressed and reversed. And then Ruth, the focus on that sort of holistic approach to eating planning and regularity, and I think the message was also to buy your plates from Matalan. I think was the endorsement that we had there. So, ladies and gentlemen, you are all here. We're here to talk to you and hear from you. I wondered if anybody had questions they would like to pose to the panel this evening. If you do, please stick your hand up. We've got a question here. So, nice big loud voice, and I'll hear from you.
So with regard to swapping over to high fibre grains, so for example, is porridge oats a good thing or a bad thing to have at breakfast?
I think porridge is good. It is good. It's not got a lot of fibre, but it has got a chemical that helps lower cholesterol, beta-glucan, in it. So it is good, but I don't feel it's the be-all and end-all. And a lot of people say to me, oh, I've been told I've got to have porridge and I don't like it. That's fine. But I think as part of a healthy breakfast kind of repertoire, it's fine. It's good.
And with regard to the natural fruits, the natural sugars in fruit, so I think I probably eat too much fruit. I do love my fruit and veg, but am I consuming too much fruit?
So regarding fruits, I think that fruit brings along with it a lot of other nutrients, not just sugar. So it's got a lot packed with vitamins and minerals. So I think it's very good, but I think you can overdo it on the fruit. In terms of diabetes and pre-diabetes, I do say to people, and we're living, and I'm mindful we're living in sort of, a lot of things are available all year round, but I think that berries are the best fruits you can have for weight management, for diabetes, pre-diabetes. So I very much encourage a staple of berries if you can. And then things like banana, Sharon fruit, pomegranate, mango, dried fruits, grapes are much higher in sugars, and not to have those on a very regular basis.
I wear a monitor, and it's attached to my phone. So when I've eaten, or if I've not eaten, I look to see what my sugar levels are, and it says in green at the top, in range. What is the ideal range for a type 2 diabetic?
So there's two parts to that question. One is what is the ideal target range, but also what's the percentage time that one needs to be in that range. So doctors often talk about time in range, and when we're trying to achieve the very best control, which may not apply to all individuals, then that is normally a time in range of 70%, which I'm not sure how strong the evidence for that is, but that seems to be what's done in a lot of the studies, and that's the current best practice.
Or before a meal, I mean, I like to come down for breakfast and have a cup of coffee and a banana, perhaps. Is that not the right way to go?
The reason I say it's not a very good breakfast is you're not having any protein with that breakfast. Protein really fills you up. It makes you satiated. It keeps you full for longer. Stops the cravings. Stops you wanting to snack later on in the day or the mid-morning. So I think it's really important. You talked about having three regular meals a day, but I think those meals need to be balanced with enough protein, etc., to keep you full and stop you snacking and things like that.
I don't know if it's a stupid question, but I'd like to ask you, if you are type 2 or type 1, is there a chance of you becoming the other one? So if you're type 1, would you ever be type 2?
It's not at all a stupid question. If you have type 1 diabetes, you could have insulin resistance as well, which is type 2 diabetes. So the health aspects matter just the same to them, but we wouldn't call it type 1 or type 2. It's type 1 with insulin resistance. Some individuals with type 1 diabetes do get prescribed Ozempic or Mounjaro injections now, and may benefit from metformin. So one shouldn't be so black and white about it. And individuals with type 2, they may actually have an autoimmune process underlying, which means they may actually end up insulin deficient, or they may end up with similar treatment to type 2 diabetes if their body cannot make enough insulin with tablets and lifestyle interventions. So the complexities of diabetes treatment for the doctor now is to not keep people in fixed categories, but to think about the person in front of them.
Thank you, panel. It's been an incredibly interesting evening. I've got a two-part question. Given how quickly diabetes research and treatment options are evolving, how confident can patients be that NHS care and guidance are keeping pace with the latest evidence? And for those who want to understand emerging research beyond routine clinical appointments, what sources would you recommend as trustworthy and evidence-based?
No one's diving for the microphone to answer that. In terms of the guidance, I think the guidance has never been better. Like a decade, when I was doing my specialist exams, I actually didn't even read the guidelines. It didn't even make any sense to me. Whereas the newest iterations of it are based on good evidence and follow the principles which I was outlining earlier. But it does require intelligence and nuance and a close patient-doctor relationship and a patient who's motivated and such like. And this is very hard to deliver in today's world when the health service is under such stress and it's hard to even see the same doctor twice in many situations, so in many settings. So I think those are where the challenges lie. So I think the guidance is good. The information which is distributed by the NHS and NICE, the National Institute for Clinical Excellence, and their guidelines are all available on the internet, though they're written more for health professionals rather than for the public. I think that's all good. Whether it's always followed is another matter. And in terms of where individuals can get information from, I mean, there are lots of resources. Diabetes UK has got a lot of good information. But often, if you're reading information online, it's not going to be, often people are trying to cover all bases and write stuff which applies to everyone, but every individual is different. So I think that's where a good doctor or nurse or dietitian comes into play, is to individualize the advice.
Just from a GP perspective, I shouldn't say this, but doesn't necessarily mean that the doctor or the GP in your practice is the best person to see. You know, there are very good diabetic pharmacists out there and nurses who do this day in, day out much more than us GPs do when we're seeing just, you know, the general things that walk through the door. And so I think it's important to seek the expert in your practice, not necessarily the GP, and build a relationship because, as Bernard said, everything is individualized and you have to have a two-way conversation with your clinician and be motivated.
First of all, thank you very much for an interesting talk. And having chaired medical discussions for something entirely different over a number of years, I'm very aware that one shouldn't make questions personal consultations. However, I have been diagnosed as diabetic since I was in my 50s, and I'm now 79. I try and follow all of the guidance, and for a number of years I wasn't treated with any medication until my blood sugar level got to a point that my GP wasn't happy. I was then fortunate enough to attend a meeting held by my surgery for diabetic patients. And I was recommended to look at the Michael Mosley book on this, I think it's called the 6-week low blood sugar diet. I followed that quite rigidly. I lost weight, my blood sugar came down. And then, since then, and it's probably about 15 years, my blood sugar went back up and doesn't come down. I have medication, I exercise, I have a careful diet, I do all the things that I'm advised to do. My question is, my GP does not have a dietitian. And because of my other chronic conditions, I need to be able to talk to someone who can understand all of that. Where do I go?
It's not in primary care. I certainly cannot get access to dietitians as a GP. Specialists in the hospital may have, with sitting within their clinics, but in the GP practice, it's really not something that's funded or available in my area. I don't think in North London either. It's just one of those funding gaps.
The rest of your story was very educational, and it was good that you shared it on many levels. One, you showed how diabetes reversal is possible for many people, but not all. And you did mention Michael Mosley and his work, some of which he wrote with Roy Taylor, who I mentioned. And that intervention you made would have certainly been a long-term investment for your health. But also the point that you made that things did then progress subsequent to your dietary intervention is a salient point, because it shows that one's not completely out of the woods and one still does need monitoring for when dietary intervention in its own may not be sufficient for some people. And that's just the way things are. And there shouldn't be stigma in that. Doesn't mean you've failed, obviously, and I'm sure you realise that. What you did was excellent. But sometimes one then still needs to have the medical interventions of medications, at least in a sensible way, insofar as they may be beneficial. But on the final point of where you can get dietary support, there's also a huge amount of information out there, which many people see to be sufficient for their own education on how to optimize their diet. It's not one size fits all, and it's definitely possible to have a very stringent diet which can be beneficial, but not for all people for all time.
There's an emphasis on taking sugar out of various fizzy drinks and biscuits and substituting it with things like aspartame and that type of thing. Do you believe that that is really better? Or, because I always think it's better not to have the sugar, but if you do have to have anything, have it with sugar because that is natural, whereas the other thing is a chemical.
Makes sense. It's quite tricky. A lot of people ask me about aspartame. I think in the food market, the low sugar foods are filled with, they've taken the sugar out and they've put sugar alcohols in, so like xylitol, mannitol, sorbitol, and those can really affect the gut and cause lots of problems. So I'm not a fan of those at all. I think it's better to have a little bit of the regular stuff as a treat after a meal. If you have something sweet after you've had a meal, so like, chicken and vegetables, then it's less likely to rush into your system and cause a spike in your blood sugars, where if you had some chocolate or sweets or cakes, biscuits on an empty stomach, it will rush in and make your blood sugars go high.
I mean, there's also been some recent studies showing that these sweeteners, etc., actually can increase your cravings for sweet things because they make things taste sweet and you want more of them. So yeah, I'm a great believer in staying clear of all the artificial stuff and every now and then having a treat.
Ladies and gentlemen, thank you very much again. Can I ask you to give a final round of applause to Dr Bernard Freudenthal, Ruth Kander and Dr Zanne Lewis on our panel. Can I also say a big thank you to everybody at the Shul who has helped us to put the event on this evening. It's been fantastic. A joy to be a part of it. Thank you very much to all of you for coming. We'll draw things to a close there. Thank you very much, everybody, and good night.